Hi, Dr. Brian Koffman, a retired family doctor, CLL patient myself, and the co-founder, executive vice president, and chief medical officer of the nonprofit CLL Society. And I'm going to be sharing with you some of the most important research that came out of the American Society of Hematology's annual meeting and exposition that was held in December of 2021 in Atlanta, Georgia, and virtually online. This is often shortened to ASH 2021. In this paper that was presented by Dr. Matt Davids and a team of other researchers is kind of a mouthful and is controversial, and I'll explain and unpack what it means and why it's controversial. The title is Matching Adjusted Indirect Treatment Comparison, Matching Adjusted Indirect Treatment Comparison, MAIC, of acalabrutinib alone or in combination with obinutuzumab versus ibrutinib or venetoclax plus obinutuzumab in patients with treatment-naive chronic lymphocytic leukemia. In way of introduction, we know that acalabrutinib and ibrutinib are both highly effective Bruton tyrosine kinase inhibitors, BTKIs, that are approved for the treatment of chronic lymphocytic leukemia and are given continuously until the disease progresses or there's unacceptable toxicity. The patient can no longer tolerate the medication. Venetoclax is a B-cell lymphoma 2 inhibitor, a BCL2 inhibitor, that's often prescribed in combination with obinutuzumab, V plus O, and it's given for a fixed duration, 12 cycles or a year, in treatment-naive patients. Obinutuzumab is a monoclonal antibody that targets CD20 and is given as an intravenous infusion. So what was the data that was looked at? Well, what they did is they weighed the data to match the aggregate baseline characteristics. What does that mean? They tried to make sure that each group of patients that they were looking at in these various trials that I'll describe in a minute that they're comparing were matched in terms of their risks. How many had 17p or TP53? How many had other high risk characteristics? So the data that they extracted for acalabrutinib plus or minus obinutuzumab came from the Elevate TN or Elevate treatment naive data that was presented by Dr. Jeff Sharman at the American Society of Clinical Oncology, ASCO's annual meeting earlier in the year in 2021. The ibrutinib monotherapy was from that arm of the large Alliance trial that Jennifer Woyak published in the New England Journal of Medicine in 2018. And the venetoclax and obinutuzumab data was from that arm of the German study group's CLL 14 trial that was published in Lancet Oncology of 2020. 3 very different trials. So what did they find? Well, the matching adjusted indirect treatment comparison. So what they're trying to do is look at these data sets and match them up so that they have similar numbers of high-risk, medium, low-risk patients, included 47 months of data from the Elevate TN trial, that's the acalabrutinib plus or minus obinutuzumab trial, 38 months of data from Alliance, that was the ibrutinib single-arm trial, and 40 months of data from CLL 14, that was the venetoclax plus obinutuzumab trial. In the acalabrutinib versus ibrutinib comparison, the progression-free survival, PFS, or the time a patient remains disease-free until the CLL begins to progress, and the overall survival, how long the patient survives overall, numerically favored acalabrutinib, but the difference was not statistically significant. The acalabrutinib versus venetoclax and obinutuzumab arm did not show any differences in progression-free survival or in overall survival. For the acalabrutinib plus obinutuzumab versus ibrutinib, There was significant difference in progression-free survival with a hazard ratio of 0.48. In other words, you had a little less than half of the chance of progressing if you were on the acalabrutinib plus obinutuzumab arm compared to the ibrutinib arm, and of overall survival, 0.41 or only a 40% chance of progressing compared to the ibrutinib arm. These were statistically significant, and I would say clinically significant. As for the acalabrutinib plus obinutuzumab versus venetoclax plus obinutuzumab, there was also statistically significant differences observed with progression-free survival favoring acalabrutinib plus obinutuzumab with a hazard ratio of 0.38 for progression-free survival, PSS, and 0.53 for overall survival. Significant differences in more serious adverse events were in favor of acalabrutinib and acalabrutinib plus obinutuzumab versus ibrutinib for atrial fibrillation, hypertension, decreased neutrophil count, and decreased platelet count. Compared with venetoclax and obinutuzumab, patients treated with acalabrutinib had lower rates of febrile neutropenia. That's where people get what can be potentially very serious fevers associated with low white blood cell counts. Also, other kinds of low blood counts were found more commonly in the venetoclax plus obinutuzumab arm. There was also lower incidence of skin cancers, non-melanoma skin cancers, and secondary malignancies. For the acalabrutinib plus obinutuzumab versus venetoclax and obinutuzumab, significantly lower rates of infusion reactions, low blood counts in skin cancers was observed with the patients who received the acalabrutinib plus obinutuzumab. So what conclusions can we draw from this? Well, based on these MAIC results, acalabrutinib and acalabrutinib plus obinutuzumab was associated with a more favorable safety profile versus both ibrutinib as monotherapy and venetoclax and obinutuzumab. These results demonstrate that, that it's also associated with perhaps some efficacy benefit versus both ibrutinib and venetoclax and obinutuzumab. But there are major problems with this kind of trial. As you can see, it's kind of a forced marriage, putting these different groups together. You have to trade off the prognostic groups that you bunch together in order to get an effective sample size. In comparison across trials is fraught with possible missteps. And the only really rigorous way to compare drugs is to compare drugs in head-to-head studies. Now, there are many reasons these trials never happen. So this type of retrospective, matching-adjusted, indirect treatment comparison is an attempt to get to better understandings of how these drugs compare. But I wouldn't put a lot of faith in these results until we look at head-to-head comparisons and better understand how these drugs compare one to another when they're studied not retrospectively, but in advance in prospective studies.